Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator. Today we are doing a throwback Tuesday back to our very second lecture together about sepsis. I wanted to revisit this because it's something I do get some questions about, and I've grown a little bit in my social media presence and my ability to kind of communicate via these recorded PowerPoints. And so I just wanted to kind of revisit this. The information I'm presenting today is not profoundly different than what I said before. I'm just hoping to dive into it a little bit deeper and maybe explain some things a little bit better about the left shift. The left shift is something that maybe we hear about, or it might be on our certification test, and we're just not quite sure what it means. So I wanted to take some time to dive into that. So sepsis is a big deal in the NICU. I think we talk about it all the time. I recently just saw this discussion post on the NICU professionals page on Facebook. I don't know if you guys are on that, but somebody said, oh, do you wear sterile gloves to handle babies less than 1 kilo for the first 3 days of life? And I was like, whoa, I've never heard of that. But I could see why that could be considered a practice that some people would do. This idea that these babies are in their most fragile state right at the beginning, they're at such high risk. The risk alone of being born premature is a risk for sepsis. So why wouldn't we? But I did a quick literature review and I couldn't find anything on that. But I just thought it was an interesting perspective, the things that we're trying to do to prevent sepsis and infection in these smallest babies. Because we know that sepsis can lead to death, and it can lead to death quickly. Also, I think it's super important to talk about sepsis because it does not just happen to premature babies. Often it's one of the main reasons that babies come to us from either a labor and delivery type unit or mom baby or postpartum, whatever you do in your facility. And they come down because they're showing signs of sepsis, or they're going to do a rule out sepsis or a rule out. And they come down to the NICU. Their parents maybe have had them up in their room for 12, 24 hours. And this is a major shock to them. So being able to kind of break it down and say, hey, this is what we're seeing. This is the signs. This is what your CBC showed. We got this abnormal CBC and we thought we got to get the babies down to the NICU. So let's walk through this. So our main risk factors for sepsis, this is the littlest part of the slide over here, kind of for a reason, because we do know those signs already. Prematurity, low birth weight, putting anything into a baby, IV, NG, central line, ET tube, those maternal risk factors, GBS, prolonged rupture of membranes, premature rupture of membranes, whatever it may be. So we know that that's what happens. So for whatever reason, there's an introducer, something introduces the bacteria to the baby, and then they have this weakened immune system from being born prematurely or something going on. So we do have two kinds of sepsis that we talk about in the NICU, which is early onset and late onset. I have seen this as a certification question, so good one to know. Early onset sepsis is that which happens in the first 72 hours, and that is primarily those pathogens that come from mom to baby during delivery. Primarily, we see group B strep and E. coli, so GBS. GBS is also interesting because we don't check for that usually until about 35 weeks gestation. So moms get that checked in that third trimester. So if babies are born before that, we don't know necessarily the mom's GBS status. So I think that's an interesting thing to kind of keep in mind. GBS is the main reason that we see very sick babies transfer from a postpartum type of unit into the NICU and get worse quickly. We had this happen in 2024 in a unit that I work on. There was a baby who was on mom baby and had one kind of low abnormal temperature. They couldn't quite figure it out. It wasn't like immediately after a bath or holding or any of those things. So they drew CBC. There were some abnormalities on the CBC. The baby came to the NICU. The blood culture was positive within 7 hours for GBS, and the baby was intubated by the end of the shift. The baby did well, got antibiotics, eventually went home. But that one temperature is what showed the nurse in the postpartum unit, oh my gosh, something is going wrong here. I've also seen that, this is a couple years ago, with a delayed capillary refill, and the baby was mottled, it didn't quite look great. Same thing, did a CBC, wasn't great, sent the baby to the NICU. The baby did have GBS sepsis as well. So it can happen, and it can happen quickly. Late onset sepsis is more of that kind of hospital-acquired things that we're exposing them to. So we did a whole lecture on infection. Go back, watch that one. It's a good one. The risk factors, what we can give them, how we can protect them. But what we really need to just think about is that every touch is a possible infection source. So are we using clean gloves? Are we going to the computer, typing in our EMR, and then going back to the baby? Those are things that we should not be doing. How do we diagnose sepsis? The gold standard is that blood culture, a positive blood culture, a foreign organism that we can treat. Obviously, our CBC might be pointing us in that direction. In micro premature babies or any baby that has been on a antibiotic for a period of time, or maybe we start antibiotics and get a CBC and then get a culture, or get the CBC, or they were on the antibiotics, the blood culture may not be positive, but if your CBC is that abnormal with signs and symptoms, it will be presumptive positive. CRPs are great if you're kind of following them as a trend, but a CRP in and of itself doesn't tell us much other than there's inflammation. That inflammation could be from infection. It could be from the ET tube being in for a prolonged period of time. It could be from a central line being in for a prolonged period of time. Maybe the baby got poked recently and there's inflammatory responses going on there. Maybe they had an IV infiltrate. So it's non-specific and it's non-localizing. It just tells us that something's going on. Now, if it's like sky high, I've seen it in the 300s, 400s, then you'd be more suspicious that sepsis was going on, and it would add to your story. We do lumbar punctures with those GBS babies and anyone that we assume there might be some meningitis going on. And then looking at our chest or abdominal x-rays, obviously looking for pneumonia, neck, any sorts of abscess, etc. So clinical presentation is crazy because I feel like if you go back to any of the respiratory lectures, some of these sound familiar for that. Probably some of these signs and symptoms sound familiar from our neck lectures, right? We did a whole month of neck. So some of these might sound familiar from that. But that respiratory distress, that temperature instability, poor perfusion. The thing I like to come back to with a lot of these things like temperature instability, respiratory distress, hypoglycemia is when you're having it in absence of a reason to be having it. If your baby has a low temperature because they got a bath or they did some skin to skin and the blankets fell off or the blankets didn't stay warm, or maybe they are hypoglycemic because we were exclusively breastfeeding, mom wasn't producing enough, or we were giving some bottles, the baby's not taking great volumes, that kind of has an explanation. But when you have a cold baby, maybe it's already well swaddled, has had great temperatures, they've had stable blood sugars while only breastfeeding, and now they're plummeting, that's when you've got to start digging. So the first thing that we typically do when we're looking for signs of sepsis is draw that CBC. These are the most common things we're going to see. There's a lot here. What we really want to focus on today, and spoiler alert for next week, we're going to be looking at those H and H's when we talk about blood transfusion, but is our hemoglobin and hematocrit are telling us a lot about neonatal circulation. Our neutrophils, which is what we're going to focus on, are telling us about our immune systems and how well we are fighting about anything that can be going on in the baby. And our platelets, which help us with our clotting. Infection will also eat platelets. So if your platelets are dropping, that can tell you that, hey, something is going on with infection, and you will often see that with neck as well. So today we're going to focus on our neutrophils. So if we come up to this line and we see our neutrophils, we have our white blood cell count and then our neutrophils. So they fight that bacterial infection. They should be a big part of our white blood cell count, and that's what we're going to kind of look at. So when we look at our white blood cell count, this is what all those different things that we see. I want you to notice this idea that we're going from immature to mature. So when you think about the bone marrow kind of being this like tube, let's just call it a tube. And the bone marrow, it has this system, and it's like, okay, as you get closer to the edge, we're going to get you out of here. So we're going to start pushing the cells out. They're going to mature as they move away from the center of the bone marrow and push out into the bloodstream. So right away, when they first come out, they're myeloblasts. They're this little precursor to neutrophils. They're not usually in the blood. If you did an actual tap into the bone marrow, you would get some. But if you're just checking a blood count, you really shouldn't see them. Same with the promos, the myelos, and maybe the metas. We are going to hopefully see those at the very low levels. And really the myelos, promos, and myelocytes, we don't ever want to see those. The metamyelocytes, the bands, and then obviously our segmented neutrophils are going to be the primary things we want to see. The segmented neutrophil is what you would call a mature neutrophil, a mature white blood cell. It's a thing out there. It's fighting. It is your strongest soldier. So my favorite thing to compare this to is people entering boot camp. So they are soldiers going in. The myeloblasts, the promos, the myelocytes, they are in their first 6 weeks of boot camp. They are learning, they are maturing, they're trying to figure things out. And the neutrophils are those guys that have been there for 12 weeks. Maybe they've already gone out to battle, they're coming back in, they're ready to go to another battle. They have the tools and the resources they need to perform at their highest capacity. These baby cells, the myelocytes, we'll call them metas because it's easier. Even the bands, they don't have exactly everything they need to be ready to go. So when those start coming in, you know that there is a danger. So when the body senses a threat, it's going to release the neutrophils. When it runs out of those, it's going to be like, okay, let's get some bands out there. When it runs out of those, it's going to get some metas out there. And you know that if your blood is full of bands, metas, or even less, that is dangerous for the baby because they cannot fight the infection as well. So a left shift is it's shifted back into the bone marrow. So this is my left hand. I feel like I need to do this backwards for you. So it's here in the bone marrow. It's making the neutrophils to send them out. And out here is where your mature neutrophil is going from left to right. So a left shift means we have come back in too close to the bone marrow. We have said to the bone marrow, release those cells before they're ready. So left shift is a shift to immature. So it's releasing the number of immature cells, especially bands, and it's a response to infection or inflammation. They are not ready to combat the pathogens. Because that neutrophil's job is really to get in there, encapsulate the bacteria, destroy it. So it needs to be fully mature, fully grown, ready to go. When there's too many immature cells, they can't capture the bacteria is going to replicate, and it's going to lead to profound sepsis. So let's look at that one more time. Here's your left. Your immature is your left guys over here. So your lefts are telling you, hey, I've got these baby cells over here. The matures are good guys. They are ready to go out here. That's what we want. We want the neutrophils mature and ready to go. With the left shift, instead of our blood being full of mature neutrophils, these neutrophils, as you can see here, have died, and instead we are releasing these immature cells. And that can lead to overwhelming sepsis because the bacteria has gotten in from one of those points of entry, whether it was mom in the first 72 hours with early onset or the hospital late onset. They've gotten in. The baby has risk factors, prematurity, low birth weight, reduction in their skin permeability, everything. And now they're replicating. And so a left shift tells us that there's too many immature cells in there, and it is a sign that the baby could become susceptible to that overwhelming sepsis and that they are not able to fight this bacteria on their own. So when we're talking about left shifts, we are often using the I to T ratio or the ANC. So the I to T ratio means immature to total ratio. So it is this long black line right here is a divided sign. I cannot, for the life of me, get this thing to do what I wanted it to do. So we're going to take the bands and the other baby cells. So that's bands plus the metas, right? So that's 4. You see that? Divided by the matures, which is the segs, plus the babies. So it's going to be, oh, that's supposed to be a 3. Really good math here, Lisa. So erase that guy, get you a 3. So we're going to do 4 divided by 64. And we're going to get a number of 0.08. 0.08 tells us that this is a pretty normal I to T ratio, right? This baby's not at too high of a risk. So that's all the I to T ratio is. The ANC is the absolute neutrophil count. So it's saying, what is our immature to mature total percentage? And you can do this by just multiplying it. So if you take the 12.5, which is your white blood cell count, and in the parentheses, you have to get them into percentages. So you're going to do 0.04, which is all of your little babies, right? The bands and the metas, 0.04 plus 6. So it's going to be 6.64 on the top. So it's 12.5 times 0.64, which is 8,000, which is right here. We want that number to be less, or if that number is less than 1,500, it can correlate with infection. So in this regard, we would say our ANC is on its way to being a marker for infection. It's not so low. Like if you have ANCs of less than 1,000, those babies can be put in neutropenic precautions because it's just saying, oh my gosh, we do not have enough neutrophils. I wanted to point out that when you're doing the bottom equation, your white blood cells, when they are reported out like this, 12.5 is actually 12,500. So you have to do 12,500 times 64 divided by 100, which is still, so this would be 12,500. In your parentheses, you have 64, and you divide it by 100, and you still get 8,000. That's just two different ways of doing the same math. But that's saying, hey, we got a lot of baby cells poking out here. So the I to T ratio, these are the same CBCs. I don't know if you noticed that. So your I to T ratio is actually looks pretty good, but your ANC specifically tells us, hey, maybe we're actually on the way down. Most EPICs or EHRs now or EMRs will report out your ANC for you. So just look for that absolute neutrophil count online on your report. Hot tip. So what do we need to tell our parents? So the big thing to know about a left shift and its indicators of sepsis is that this is new and different to them, and it's something that we have to go looking for, and we're probably looking for it because we recognize that something was wrong. And so the parents, as our primary caregivers, will probably be the person that maybe noticed this. So encouraging them what signs of sepsis are, to communicate with us if they notice anything is different. Hand hygiene, wiping on your high-touch surfaces, getting in and making sure that we get like our clean area and our dirty area when we're talking about the baby in the incubator, so that the parents can really be that big part of it. The things that they can do for the positive things for infection, like skin to skin, OIT, like I said, wiping on their high touch surfaces, not coming in when they're sick, etc. They're going to be the best things that they can do to help prevent sepsis in the left shift for their baby as well. The big thing about prognosis with sepsis is it really does depend on how quickly we catch it. Those two babies I was telling you about that transferred to us from mom baby, one of them did not survive their sepsis, their GBS sepsis. And that baby, it was caught as quickly as, possible. But GBS replicates extremely fast in the baby. So prompt treatment, recognizing that something's wrong, listening to your gut. The one with the low temperature, I can imagine having one low temperature and kind of writing it off as like, okay, it's probably okay. The temperature was pretty low, so she did listen to her gut. But what else can we do? Remembering how we as bedside nurses can help these babies. Wipe down our high touch surfaces, use breast milk. Don't put in a central line if we don't absolutely need one. Getting the central line out as soon as we can. Making sure we're checking our IVs. Having our parents know that they are there as the constant number one caregiver, that they are going to notice those subtle changes in their baby. So thank you for joining me on Sepsis 2.0, where we dove into the left shift. If you have any questions, let me know. Next week, we're going to dive a little bit more into another part of the CBC, and we're going to talk about blood transfusions. So join us then and have a great Tuesday.